Thanks for joining us today for the final Alcohol Policy in Canada webinar, everyone. I see people joining fast and furious. If this sounds right to you, welcome. You're in the right place. This webinar series, exploring the current state of alcohol policy, public health, and cancer prevention, has been organized by the Canadian Partnership Against Cancer, the Canadian Public Health Association, the Canadian Centre on Substance Use and Addiction, and the Canadian Cancer Society. A big thanks to the team behind the scenes from all four of these organizations who have made this series possible. You're the best. My name is Michelle Halligan, and I am the Director of Prevention at the Canadian Partnership Against Cancer, and I'm pleased to be your facilitator for today's final session. As many of you are aware, the COVID-19 pandemic and response has resulted in increased alcohol consumption and shifts to alcohol policies, in many cases loosening of regulations. Because of this, there was a desire to convene professionals and thought leaders in the areas of alcohol policy, public health, and cancer prevention to discuss the current state of alcohol policy in Canada and evidence-informed actions to move us forward. The purpose of the webinar series is to reignite discussions on approaches to reduce alcohol consumption in Canada. Today's webinar is the final of 4 that were offered this fall. Recordings of these webinars are available on the Canadian Public Health Association's YouTube channel for your viewing pleasure. Today's will be available later this week, so don't feel the need to jot everything you're seeing down or trying to screenshot everything you're seeing in front of you today on Zoom. Today, in our final webinar, we will turn our attention to alcohol policy actions. And I know we had great interest over the past few weeks in these series, and we're expecting about 400 people here today from registration. So welcome to everyone. It's a pleasure to have you on board today. A little bit of virtual housekeeping. I'm sure we're all pretty used to virtual platforms these days. Welcome to Zoom if you haven't been on it before. To minimize disruptions during today's session, we have muted all participants. Please feel free to use the Q&A function to pose questions at any time during today's presentations or panel discussion. Elizabeth is our moderator. She's looking at these, organizing them, and we'll do our best to get through as many as we can. You'll notice this is a meeting that's being recorded. As I mentioned, it will be available as well as materials later this week on the YouTube channel from CPHA, and you will also receive an email notification if you've registered when they become available. If you're experiencing any technical difficulties, sure hope you aren't, but that's something that's pretty normal. If you can't see the slides, if you can't hear properly, please use the chat function if it's available to you, or email webinars@cpha.ca. If you're really having troubles hearing via the Zoom platform, feel free to hang up and join via phone. Look for those details in your invitation. So, I'd like to get us started for today. We have representation from across Canada today on this webinar. I'm located in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is also home to many diverse First Nations, Inuit, and Métis peoples. I'm committed to taking action on reconciliation. And last night, while I was thinking about my remarks today as facilitator, I reflected on and considered how important language and bias is in relation to how we describe risk factors for cancer and alcohol consumption. And it got me thinking, perhaps instead of using terms like indigeneity as a risk, we should consider that as protective and flip the narrative to colonialism as a risk factor. I'll continue to understand and implement taking a strengths-based approach to my work. I'm on a journey, and I invite others to join me and others across the country on this journey. Today, I am so pleased to introduce 2 presenters who are going to take you through some exciting work that is happening here in Canada. First, we'll hear from Dr. Bryce Barker, who's a knowledge broker at the Canadian Centre on Substance Use and Addiction. He's co-chair of the Post-Secondary Education Partnership on Alcohol Harms and is involved in alcohol and workplace-related projects. His background includes work in the area of substance use, addiction, and mental health. And then we're going to hear from Dr. Natalie Brender, who is the Director of Policy at the Canadian Public Health Association and a public policy professional with experience in research, analysis, communications, and advocacy. She holds a PhD from Johns Hopkins University and has held senior positions in the federal government, the Conference Board of Canada, and most recently, the Social Sciences and Humanities Research Council of Canada. I'm now going to turn it over to Bryce.
Thank you very much. Please bear with me while I get my slideshow up. And maybe if Michelle, you just let me know that you can see this okay, that'd be great.
Looks good, and I can hear you well.
Excellent. So good morning or afternoon, depending on where you're joining us from today. So alcohol cost Canadians $16.6 billion in 2017. So these costs are measured across healthcare, lost productivity, criminal justice, and other direct costs. But what we don't see in these high-level numbers are the tragic consequences related to alcohol use for Canadians, for their families, and for communities. So one of the most effective means at our disposal to address alcohol harms are the development, adoption, implementation, and evaluation of effective alcohol policies. So in each of our own contexts, we have an opportunity to be aware of what's most effective and hopefully apply that to guide our work. So today I'll share some international evidence, Canadian evidence, and speak about the National Alcohol Strategy recommendations. So people joining us might be aware of Best By interventions, but for the rest of us, about 10 years ago, in a WHO report on non-communicable diseases, it was established that cardiovascular diseases, cancers, chronic respiratory diseases, diabetes, and mental illnesses accounted for 63% of all deaths around the world and were a major threat to human health and flourishing. In a report published around the same time, the WHO referred to a set of highly cost-effective interventions that would provide an extra year of healthy life to populations worldwide. These interventions were relatively cheap to implement and had the potential to have a significant and positive impact on people's lives. Some interventions were considered best buys, so the most effective and also the least expensive interventions. The best buys to address alcohol were established after evaluating 42 alcohol policy interventions, and it was found that the most cost-effective measures for alcohol, or the best buys, were increasing alcohol beverage excise taxes, restricting access to retail alcohol beverages, and comprehensive advertising, promotion, and sponsorship bans. In 2018, the SAFER initiative was launched by the World Health Organization. There is an action package that goes along with this package to support countries using high-impact, evidence-based, and cost-effective interventions. So the SAFER initiative expanded beyond the original 3 best buys and included 2 others for which the cost-effectiveness evidence is also convincing. So these are advancing and enforcing impaired driving countermeasures, facilitating access to screening, brief interventions, and appropriate treatment. The package noted that implementing SAFER would save 100,000 lives by 2030 and provide $9 in return for every $1 invested. The evidence suggests that these types of interventions have the highest return on investment. What this means is that countries like Canada, committed to reducing the 18,000 deaths per year caused by alcohol, can actually do so by implementing these best buy interventions that are supported by the available evidence. In Canada, similar work has been done, identifying alcohol policies with strong evidence that can be implemented at the federal, provincial, and territorial levels. So most recently in 2019, a team of researchers led by the Canadian Institute for Substance Use Research, and the Centre for Addiction and Mental Health worked with other scientists to lead a national evaluation of alcohol policies that apply to the federal government, provinces, and territories. So it's called the Canadian Alcohol Policy Evaluation, or CAPE. So they identified 11 key policy domains and interventions that could prevent reduce alcohol-related harms. Their work was based on systematic and thematic literature reviews of the best available evidence. So there were 7 direct policy domains that they covered. Those included the 5 that I covered for SAFER, but also included minimum legal drinking age and liquor law enforcement. So just like the WHO, the CAPE report highlights that jurisdictions should have hours of operation set by regulation to work towards a gold standard best practice for physical availability. But in the Canadian context for CAPE, there's also more specific recommendations. So for alcohol that's sold to be consumed off premise, they're recommended, the gold standard recommendation is that it should not open before 11 a.m. and should close at 8 p.m. So for places where alcohol is going to be consumed on premise, they should not open before 11 a.m. and should close at or before 1 a.m. the following day. So CAPE also identified some indirect policy domains. So these are an alcohol control system, an alcohol strategy, monitoring and reporting, and health and safety messaging. So as Aaron Aubin covered last week, so indirect policy domains like health and safety messaging can actually help direct policy domains. So in the case of health and safety messaging that talks about the link between alcohol and cancer, when people hear about this link, they're more likely to support direct policy domains like taxation. So the report took the research a step further to evaluate progress towards gold standard alcohol policies. They highlighted overall that policies at the provinces and territories and the federal government were failing to implement the policies that would promote health and protect Canadians. Some notable strengths of the existing federal policies included increase in alcohol excise tax rates and the reintroduction of annual cost of living increases for alcohol excise tax rates, strong ongoing funding and support for screening, brief intervention, and referral programs. The overall score is also low at the provincial and territorial level. However, many individual examples of best practices that were implemented at provinces and territories were there. And if they were all implemented, the overall score would have been 87%. So it means that there's possibility for improvements, and the improvements are feasible. They're already happening in different provinces and territories. So next, I'll talk about Canada's National Alcohol Strategy, and more specifically, the refresh of this strategy. So in 2007, the National Alcohol Strategy Advisory Committee reached consensus on 41 recommendations that recognized a role for all stakeholders in the field of alcohol to minimize alcohol-related harms. In 2018, the advisory committee members agreed to refresh the recommendations. This was based on just the need for them to be updated, but also calls from the Standing Committee on Health and the federal health minister to update the National Alcohol Strategy. For the updated NAS recommendations to be useful, they will clearly define activities to commit to and help to focus on indicators of key outcomes. The focus of the main outcomes of the NAS recommendations are summed up in 12 areas, which are very similar to the CAPE project. For each component, the specific question that we were pursuing was whether there was updated scientific evidence that justified updating NAS recommendations and to figure out which direction the evidence was pointing. We developed a summary brief of key scientific reviews and meta-analyses that was developed and shared with a scientific expert working group composed of Canadian and international researchers. Working with the guidance of this expert group, the updated recommendations also explicitly considered WHO, CAPE, and provincial level recommendations that were developed by the Centre for Addiction and Mental Health. The overall intention was to provide evidence-based direction to update the National Alcohol Strategy recommendations. On that basis, the NAS recommendations has identified 4 key areas for the federal government to address alcohol. So these areas are support for public education, monitoring and surveillance, advertising and marketing of alcoholic beverages, and fiscal and pricing policies of alcoholic beverages. So we've continued to engage with the health minister and tried to highlight how impactful making some of these policy changes can be. There are also important actions that can be taken at the provincial and territorial level. These include supporting intervention and treatment, regulating physical availability, especially in keeping with the CAPE gold standard recommendations, and implementing fiscal and pricing policies on alcoholic beverages. We are compiling all of the recommendations into a report. We're planning to release that in March 2022. So what can you do with this information? So if you're in a position to do so, you can support evidence-based policies, alcohol policies. You could share these evidence-based policies in your setting. If you're in an opportunity to discuss this area with an MVP or an MPE or senior leadership team, you can make sure that they're considering the best evidence for alcohol policy, especially, and we've seen some of this in COVID-19, where some of the best policy areas are being undermined, knowing that, again, an indirect policy can affect some of these direct policy domains. Just thinking about what is happening in alcohol policy in your area and how it reinforces or detracts from best practice. So now I'll hand the presentation over to Natalie Brender, and she'll expand on some of the harms of alcohol and talk about complementary work from a public health perspective in this area. So Natalie, you should be able to share now.
Yes. Okay. Sorry, there's something going on with my screen here that is getting in the, oh, there, okay, yeah. So is my screen sharing now? No.
I can see your note screen at the moment. So you just have to, so from beginning or the slideshow. Yep, click that one.
There, okay, thank you. Okay, thank you everyone. And thank you for this opportunity to share some details of the upcoming report from the Canadian Public Health Association that we will be releasing in spring of 2022, which is a public health perspective on alcohol consumption in Canada. It reflects CPHA's membership, which consists of the diverse professions within the area of public health, and our policy mandate, which is to represent and advocate for national and provincial, territorial, municipal level policy changes to advance public health in Canada. How was our statement developed? Well, we started with our 2011 statement and then looked at changes in the policy sphere since then. We consulted the latest evidence. We talked to our own public policy committee and our members and our board, and it's now being reviewed by various internal committees. And above all, we aimed this statement to reflect a public health perspective on the issue of alcohol consumption and its harms. So what is a public health perspective? For those who might not be familiar, just a reminder. First of all, it is evidence informed. It is informed by multidisciplinary evidence, quantitative and qualitative, that looks at communities, various segments of populations, and pays attention to what is known and what isn't known about these populations and their relation to alcohol policy, or alcohol use and harms in this case. The aim of public health is to maintain and improve the health of populations on the basis of principles such as social justice, attention to human rights and equality, and always evidence-informed policy and practice. It addresses itself to upstream factors, that is, not looking just at the immediate individual choices that lead to health inequities and harms, but looking at what factors place individuals and communities in situations leading to harmful alcohol use and what can be done to address the causes of those factors, which we call the social determinants of health. And the approach that we tend to recommend is one of targeted risk reduction that meets people where they're at. In other words, it looks at the status quo through a public health lens that aims at reducing upstream factors and above all to reducing harms and health inequities. So what does our report find? Well, first of all, it finds that there are really important population level differences in usage patterns of alcohol and harms with respect to alcohol. Just to give you a flavor of some of these population level note findings that we point out, in 2015, about 15% of alcohol drinkers in Canada exceeded the low risk alcohol drinking guidelines. Heavy drinking occurs most frequently in people aged 18 to 34 years. is reported over twice as often by men rather as opposed to women. Rates of alcohol consumption and heavy drinking vary by province and territory. Residents of rural areas are more likely to report heavy drinking than residents of urban areas. There are lower consumption rates among many ethnic and racialized populations compared to whites. And there are other associations with social determinants of health, such as differences in rates of heavy drinking according to sexual orientation among women, but not so much among men. And different rates of heavy drinking reported according to income and occupational categories. So all of these findings show that it's essential to pay attention to the determinants, social determinants of health and the patterns of inequality they produce. We also do pay attention specifically in our report to alcohol policy with respect to Indigenous peoples, not with the aim, of course, of increasing stigma, but as a way of reflecting the priority that CPHA places in our strategic plan on truth and reconciliation, and as a way of responding to the calls in the Truth and Reconciliation Commission, their calls to action with respect to health. For example, among the calls are ones that call on the government to acknowledge that the current state of Aboriginal health in Canada reflects previous governmental policies, calls to identify measurable goals, to identify and close the gaps between Indigenous and non-Indigenous health in areas such as addiction, and calls to address the distinct needs of Indigenous peoples on and off reserve, as well as to recognize the value of Aboriginal healing practices. So those are the reasons why we do pay some specific attention to this topic in our report. What we find, just to give a brief summary, is that there are higher rates both of abstinence and of risky drinking among Indigenous youth and adults writ large compared to non-Indigenous populations in Canada. And there are disproportionately high rates of fetal alcohol syndrome disorder. And these statistics do, of course, reflect the effects resulting from racism, colonialization, cultural genocide, which resulted in the erosion of family and social structures and intergenerational trauma, leading to these health inequities. So there are cultural interventions that have been pioneered and developed by Indigenous peoples, particularly in the framework honoring our strengths, and in which lays out many approaches, culturally appropriate approaches to intervention for alcohol use. And CPHA, we do encourage Indigenous governance organizations to consider applying the recommendations in our report to their own contexts as they best see fit. So the recommendations that we put forward to government as a result of our review, they fall into three main buckets. The first has to do with data and evidence. First of all, we called for there to be national standards for data collection that include race, ethnicity, and economic status. Because right now the evidence we do have is old, it's very partial, it doesn't, it's internally contradictory, and we need much better standards. Secondly, we call for more research to be funded and conducted into the causes of alcohol overconsumption and into modes of intervention that can address those causes. And obviously modes of intervention that are tailored to specific populations and their needs and realities. The second basket of recommendations to government has to do with approaches to controlling the harmful use of alcohol. We call for governments to conduct an evidence-based assessment of the effectiveness of the current federal approach to alcohol control, and to consider whether controlling alcohol more like tobacco and cannabis would do better at minimizing harms than the current regulatory regime. Third, we call for a group of recommendations related to intervention, such as stronger regulation and enforcement with respect to marketing and promotion of alcohol. There needs to be interventions better targeted to specific populations, such as youth, such as heavy and high-risk drinkers, and pregnant women. There need to be continued focus on adopting the best evidence-based programs, initiatives, treatments, and modes of support. And this means ongoing assessment of what kinds of interventions are currently working well and which ones aren't. And so discontinue ones that are clearly not best practice. There need to be recommendations that are trauma and gender informed and culturally appropriate, in recognition of the fact that harmful and risky alcohol use often intersects with other kinds of health inequities and the harms that they produce. And there need to be interventions targeted toward the reality that alcohol is often related to intimate partner violence and other forms of violence. So there need to be interventions addressed to those areas as well. Thank you so much for this opportunity to share our findings. Please do keep open your eyes for our report that will emerge in the spring. Thank you.
Thanks so much, Natalie and Bryce, for those thoughtful presentations. I heard a lot of really interesting points shared across your presentations about what is possible in Canada. We heard about evidence-informed policy actions that can be taken on an international level, on a national level, at a provincial, territorial, or local level. We've heard about work in our own backyard here in Canada in relation to the evaluation of the current state of alcohol policies, thanks to the work by the CAPE team. Canada does have a national alcohol strategy and it is being refreshed. That's pretty exciting. Not all countries in the world have that type of momentum or plan in place. So excited to hear more in the coming months about how that work will be refreshed and shared with the public health community. Natalie, thanks so much for sharing reflections on the work at the Canadian Public Health Association on that position paper that will come out soon. Really interesting thoughts about population-based approaches, more relevant interventions that consider upstream determinants of health, taking that trauma-informed approach, a culturally appropriate approach, and lining up with a lot of conversations that we've heard from the COVID-19 pandemic about really that need for better data on race, ethnicity, and social economic status. So thanks both, a lot of food for thought. And it's now my pleasure to introduce our expert panelists with all of you today. So I'd like to invite Candice Aubin, who is the Vice President of the Health Promotion and Chronic Disease Prevention Branch at the Public Health Agency of Canada, to turn her camera on. Her work with the Canadian Public Service has had a large focus on policy and programming founded in the social determinants of health, in particular as it relates to Indigenous individuals, families, and communities. Candice has a bachelor's degree in psychology and a master's degree in Canadian studies with a focus on Indigenous children's rights. She is an Algonquin Anishinaabe woman who is passionate about equitable public health and health promotion across the life course. Thanks, Candice, for being here. Dr. Strang, I'd like you to also turn your camera on. Dr. Robert Strang is Chief Medical Officer of Health in Nova Scotia, appointed in August 2007. He provides leadership around the renewal of the public health system in Nova Scotia, as well as raising awareness around the importance of creating policies and environments that support better health. Dr. Strang received his medical degree and completed his family practice and community medicine residencies from the University of British Columbia. He holds an adjunct appointment with Dalhousie University in the Department of Community Health and Epidemiology. Welcome, Dr. Strang. Welcome, Candice. Really pleased to have you with us today as our expert panelists. And we have many, many questions starting to come in from our passionate and participants here. I just want to remind everybody, please use the Q&A feature, and I will try to get through as many of the questions that are coming through. So while we get those organized very, very quickly, I'd like to ask each of our panelists to share a little bit more about themselves, including maybe what keeps you up at night in relation to alcohol policy. So please, I see you both on camera, unmute yourself. We'll start first with Candice.
Thanks, Michelle. Kwe, Candice Saint-Aubin, Indigenous Caz. Hello, my name is Candice Saint-Aubin. Bonjour, je m'appelle Candice Saint-Aubin. Like some of you already on the call, I'm coming to you from the unceded traditional territory of the Anishinaabe Algonquin people. It is a privilege and an honor to be here. And Michelle, I just need to call out right now, I even took a note of it, colonization or colonialism as a risk factor. Beautiful. Flipping that narrative. What keeps me up at night? I have to say that naturally COVID, working with the Public Health Agency and the public sector writ large and COVID response has been a big lift for the federal public service. But now as we're kind of shifting, certainly in my space, shifting our thinking to those wider health impacts of which alcohol, as well as other substance use, becomes really a critical space that we need to unpack and dive into. I've had the honor of meeting with our Minister of Mental Health and Addictions, or problematic substance use, as I like to call it, but Carolyn Bennett, who I had the honor to work with when she was under her previous portfolio in the Indigenous files, both at CERNA or Crown Relations and Indigenous Services. This is an exciting time for me. It keeps me up in a good way because now we have a dedicated minister who is, a practicing in medicine, who understands equity, who understands the fact that we need to not just look globally in our response or our actions and certainly our data, but really unpacking that disaggregation. And she wants to get in there. Minister Bennett is somebody who, again, because I've seen her in action, wants to understand and wants to meet with people and wants to have the lived experience, either those living currently or have lived the experience. So for me, it's extremely exciting. And it keeps me up in that, I don't know if I can keep up with her because she's just so energetic. But, and then of course, spending time with Dr. Tam throughout the pandemic and Dr. Tam's passion for public health and the social determinants at the starting point, I think has been just, it's just been such a great time to be at in the government and doing what I do. I'll pause there.
Thanks, Candice. That is exciting. What an opportunity we have with a minister that's focused on mental health. Woohoo! Go Canada for that. Thanks for those reflections. Dr. Strang, over to you and what's keeping you up at night.
So thanks for the opportunity of being here, and thank you for getting my headspace into something other than COVID. That's quite a luxury, and I appreciate that. So I'll set COVID aside, other than to say, I think there is, like Candice, I share her excitement and enthusiasm. There is opportunity. That I think starting with COVID, there's a lot of work we need to do around what have been the impacts of COVID, and certainly substance use and problematic substance use tied in with significant issues around increases in depression, anxiety are issues that we need to put at the forefront. So that gives us an opportunity, having a federal minister of mental health and addictions. And I'm also pleased to say that Nova Scotia has created an office of mental health and addictions that is working very closely with public health. So then again, that to me creates opportunities with more attention and a specific government focus directly on mental health and addictions. For those who don't work in government, just the fact that it's created, especially at the federal level, a department with a minister leading that and specifically naming those as issues is big. That creates opportunity. The third opportunity, maybe we'll get into it. I think we're a few years into cannabis legalization. Guess what? The sky has not fallen in. But why is that? How have we legalized cannabis and created a regulatory structure that hasn't led to significant increases in consumption, et cetera? So there's, I think, putting all those three together, and well, those are the last one. We know that COVID clearly has highlighted very stark inequities in our society, and who is much disproportionately impacted, including, and then we have to tie that into how does that then help us frame the discussion around mental health and addictions, and who is disproportionately impacted in both those issues. So putting those all together as a package, I think there is, for me, and hopefully we can come back to this, I think there is an opportunity to start a very different conversation around how we regulate alcohol policy, and how we bring Canadians along. Because I think there's some underlying reasons why we haven't been able to move the yardsticks very much in alcohol policies, because Canadians aren't willing to have that conversation. So we have an opportunity and a starting point to change that dialogue.
Thanks so much, Dr. Strang. And Dr. Strang, longtime alcohol policy champion. So lots of questions coming in that you touched on as well. So I'm going to get us started right off the hop on something that both of you have spoken about, and I know is within both of your files. I'll start with you, Candice, and then Dr. Strang, feel free to also give your 2 cents on this. What could taking an equity-focused approach to alcohol policy look like? Some questions came in around how we might include diverse voices and focus on representation and how we move forward on alcohol in Canada.
Yeah, that's a great, that sounds so cliche, but that's a great question. It really is. And I think it goes back to what we're saying, that the equity, the health equity or the social determinants needs to be the starting point for everything, right? And Dr. Strang mentioned the fact that COVID just in itself has really brought to light that populations are impacted differently from things like these, emergency situations, but they've also been affected outside of COVID, right? But we've never had an access to unpacking who, what, where, how, and why. Our responses have been pretty global in nature, right? Global advertising, campaigns, global public education. And I think where we build on equity, and certainly we have that's our starting point from my branch, is around surveillance. It's around data. It's that monitoring, but also that disaggregated data. That is a challenge. And that is where it really boiled down to in the COVID context for us, is that we have a problem, a gap, if you will, on accessing that type of data. Our systems, as most can attest, are codependent on each other. We're across multiple jurisdictions, certainly in public health. So our data systems nationally are only as good as how they speak with the provincial territorial systems, and are we counting the same apples to apples, oranges to oranges, so that we can really see what the impact is on community X versus community Y. And then within those communities, going even further down, what are those ages, genders, certainly cultural contexts, geocultural contexts. This has become, certainly for us, a real driver for the types of funding interventions that are offered within our suite of program services and funds, because it has to be based on some sort of evidence, but it's finding the evidence. So we've shifted some of our programming certainly to ensure that, for example, we know that mental health and substance use are pretty intertwined, right? They're pretty, right in there. So we have a program, just say like mental health for Black Canadians. Well, that fund, if you will, was developed, implemented, and rolling out with Black Canadian leaders in those communities themselves, dictating and identifying those outcomes to ensure that it meets their community's needs. So we're trying to shift to ensure that it starts at the very beginning, from the evidence into development and then application. And it has to be very focused on both individual and population. I don't know if that's at all of relevance. Dr. Strang, if you want to add to that.
Yeah, maybe I can add in. And so I'll come back to my point around and I really believe this, is that we need to have start a different dialogue around alcohol. We're not going to get politicians making the fundamental changes in alcohol policy unless they feel that that's something Canadians want. That's just a reality. So how do we start a dialogue that really says, let's talk about how alcohol impacts our communities. There may be benefits, there's certainly lots of harms. And to me, then there's an equity piece in that, is that which communities are we actually bringing to having to the table to hear from them about how alcohol impacts them in their communities. Mm-hmm. That to me is really what we need to do, is start a very different dialogue that I would say would bring right onto the table all of the ways that alcohol has harmed communities for generations. Mm-hmm. and then we need to bring also the epidemiology on that as well. So I just see somebody with making a question about cultural shift. It really is about unless we can get a very cultural shift around how we think about and what space we give alcohol in our communities, we're not going to be able to overcome the big industry and their influence on politicians.
Yeah, and I would, Dr. Strang, even going so far as to say that industry also needs to be at the table. I think that governments can talk and talk and talk and try and devise, like you say, it needs to be a culture shift for sure. Certainly to destigmatize, right? So it's something that is openly discussed, but also that, you know, industry has a place there. They need to be a part of the conversation and understand from an equity lens, like it's not all or nothing. Like there has to be some sort of sequential gain in that space.
Yeah, and you know, you're absolutely right, and I agree that we need to say, you know, we have to acknowledge that there are a lot of jobs, there's a lot of economic benefit in communities from whether it's manufacture, you know, the winery business, whether it's craft breweries, whether it's the sale and distribution of alcohol. We do need to acknowledge that. But I would also say, if we bring it's not just bringing the alcohol industry to the table, let's bring all of the business sector to the table and let them say, oh, how does alcohol misuse have an impact on workplace safety, on productivity? And so you have a range of other businesses and business leaders along with the alcohol industry speaking the truth about alcohol and its impacts. And yes, we do there are benefits from alcohol, but let's be much more honest and clear about the costs and have that very deliberate dialogue. And then, but I also think that really, it's not just the alcohol industry. I think to me, that's really important. They have a significant presence, but we need to match them up, if you will, with other business and industry sectors that can speak the truth about how alcohol impacts them.
Thanks both, and you're reading our participants' minds. Thank you both, because you're touching on things I'm seeing coming through the Q&A about wine and cider and craft beer and industry presence, and that being an economic driver for some communities, and thinking about getting more tailored in what's going to work for different communities and bringing different voices to the table. I'm going to touch a bit on what we've seen since COVID, and I'm seeing this in some of the questions, is that a lot of policies are starting to be loosened, particularly at the municipal level, in relation to allowing drinking in public spaces in a way that perhaps haven't been before. Made a lot of sense for communities, right? Can't gather indoors, can gather outdoors, and there are economic interests wrapped up in all of this. I want to get thoughts from both of you on what types of supports we can lend to our colleagues working at the local level that are experiencing some of these shifts. What are options for opening dialogue on potential harms or other interests? And you started to bring some up in that former dialogue. Perhaps Dr. Strang, we can start with you.
So before I go there, I mean, the policy issue you used is that I think we need to be thoughtful Is it really such a bad thing that if we are allowing kind of alcohol or designated alcohol consumption spaces in public areas? I think we've got to be really thoughtful of in the conversation around alcohol. We're not about prohibition. There is a place for people to safely use a moderate amount of alcohol. So is it really a bad thing if we allowed like public parks where families could have a picnic, and maybe if they chose to have a glass of wine or something, there could be a section where they do that? I think if we're too rigid or extremists, we lose a lot of people in the conversation. So I just think that, and the answer may ultimately be no, we don't want those spaces. But when I looked at the questions ahead of time, that to me is a policy issue at the local level. They go, really? Is that one that, you know, how much do we want to fight that? Or is that one where we actually want to be seen to be reasonable? How do we create an appropriate approach potentially, so there is some ability to have alcohol consumption in a moderate, safe way as part of public spaces? I think that's a dialogue. And so the point is that what are the real policy issues which we really want to push on, and what are the ones that we actually if we want to avoid seem to be extreme about? And to me, the big ones around how alcohol is sold and marketed, those are the ones that are the real issues we want to get behind. So the other point about that is, where do we go with that, you know, at the local level? And I think it is about, before we get into what is a policy solution, having that conversation, or that what we talked about earlier, let's start a community dialogue about how is alcohol showing up in this community? What are the things that we're okay with, but what are the many challenges and the harms that up till now are really, for many reasons, are quite hidden, and we don't want to talk about it. We don't want them to recognize them. So spending the time to start that dialogue before we actually get too much into some of those policy solutions. However, having said that, you know, I think where we really need to push hard at a national level is learning from cannabis and tobacco, and then saying, well, and having the start or the discussion about why is it so starkly different from how those products are sold and allowed to be marketed than alcohol.
Thanks, Dr. Strang. And maybe I can push us in that direction and say, what should we be considering from that experiment that we've just been through now that we've, you know, legalized cannabis and we're regulating it across the country? What can be drawn from the cannabis regulation journey we've been on for alcohol?
Well, if unless Candice wants to go, I'll jump. I mean, I think we need to start to look at it. And again, with tobacco, you know, we've got two products, tobacco and cannabis, which they're psychoactive substances like alcohol. We allow them to be legally sold. And there's lots and lots of discussion out there around any kind of substance, psychoactive substance. The safest approach is to have some kind of government oversight on sale and regulation. And so I think we can put those three together and say, how is alcohol so starkly different from cannabis and tobacco, and why? And when you really look at it, it's around how we control price, how we control in everything we put in place to really substantively control the marketing and the advertising around cannabis. I think those to me are the places to start. You know, I was involved in the cannabis legalization, and it hit me every time. Well, we're doing that for this new product. Why can't we do that? If the intent of that was to actually allow a product to be legally sold, but to minimize harms, you're not trying to increase consumption. Then there are certain policy principles, and to me is we need to look at those. And there are certainly some things starkly that we would say that why is it so different, and should it be so different for alcohol?
And just to jump in from my space, which is really just public policy, you know, and outside of the medical elements of it too, I would say though is that just off the top, tobacco is, I think, a good reference point, because again, it was going from a socially acceptable, commonly used product into something becoming far more regulated through certainly advertising, costing and taxation, unlike cannabis, which was coming from a place of heavy enforcement, not socially necessarily acceptable en masse, to bringing it up. And it was a long road to legalization of cannabis, right? Like, this is well over a decade or more of conversation, and we're still learning about the longer term medical impact, et cetera, and on all use fronts and within Health Canada's world. There is, though, I think some opportunity to explore its impact, and certainly on use, safe consumption. And I've been reading the comments, and I just saw one saying that, you know, maybe we need to be clear that there is really no necessarily a safe amount of consumption, because it really is independent or dependent on person. But like you saying, Dr. Strang, it's not about being prohibitionists. You know, it's about, you know, moving towards moderation and in a way that makes sense. I always point back to the fact that, you know, cannabis too is still pretty new in this space of legalization. So for me, and purely where I sit with public health, is we are monitoring it. We need to know, you know, 5-10 years from now, what does it look like? Again, alcohol has been consumed, you know, social norms, if you will. It's you know, very prevalent. So shifting gears, much like tobacco, will have positive and certainly negative blowbacks that we'll need to consider as we move together into a national kind of dialogue on it.
Thanks so much, both. And I think you've touched on a lot of things coming up in the Q&A about lessons from tobacco and the glamorization, perhaps, of alcohol in some of the things that are allowed in terms of marketing and advertising. So thanks both for your reflections on that. I'm going to take one more question because it is 12:51 where I am. Today we have just flown through. I think we could spend all afternoon together. Wouldn't that be indulgent? No COVID for either of you for the rest of the day. Ha! Good luck on that. So the last question, and Candice, this one is probably going to be one that you might have some reflections on. It comes from a colleague working in health promotions with nations in Treaty 3, 5, and 9. These nations, or some of them, are considered to be dry and sober by policies in the community. And, you know, that's, you know, not always a reality. So there is alcohol in community, but because they're deemed dry and sober by policies at the community level, leadership within the community can sometimes be resistant to health promotion or harm reduction type approaches. Do you have any recommendations about how to reach out to community leadership? What would be a starting point? What's a way to open this conversation?
This is conversation for the ages, I feel. So, you know, self-determination and autonomy and is paramount. It's critical, and it's just a non-start. Like, that is where it starts. So leadership has determined their policies, be it dry policies or what have you, and that needs to be respected, right? And it comes down to various levels of enforcement, from pure banishment, which we've seen certainly in non-alcohol substance use cases, to, you know, less kind of, that's kind of the far end of it. You know, the best you can do is just to be proactive in sharing information, but still respectful of that authority. Anytime opportunity for conversation, you know, and I think communities, especially, we know, we've seen anecdotally, I can only speak to anecdotally at this point, but, you know, dry communities, there's always a pipeline coming in of some sort of substance or substance alternative to, you know, what would be mainstream substances that are being consumed. I just think, you know, there's times where community members fly out, if they're flying communities, or leave community to access other public health services or healthcare services. So those are opportunities for conversation and for sharing of public education. You know, really, those are the at least entry points. Post-secondary education institutions, K-12 education institutions as well. You know, we do have a lot of community members who leave community to go to school, go to work. You know, going into mines, you know, Ring of Fire, and I think about Northern Ontario, these types of things. Those are opportunities to engage teachers, education, public school systems, certainly medical healthcare systems, but as well as unions, employers, you know, to gain any opportunity to distribute and share public education on alcohol-related harm is just a win. Anyway, any context you can, but you still have to acknowledge and recognize the authority of leadership as elected by their community.
Candice, those are such helpful reflections and important ideas for all of us to think about those. Any opportunity. How do you integrate culturally appropriate messaging into the spaces that already exist?
And just to say, if you can use it in a traditional Indigenous language, any documents that you have, publications, try to get them translated, you know, and work with community translators or those who have lived in community who know the language, just to make it, again, it's that cultural element and context, you know, it's so vital.
Thanks, Candice. So I want to say thanks so much to Candice and to Dr. Strang for spending an indulgent hour with us today. And I hope it was a nice break for your brains from some COVID-related things.
Always.
Yes, thank you very much, very much. And then I look forward to more opportunities as we move beyond COVID, but to learn from COVID and to be involved at various levels around alcohol policy conversations.
You should see when Dr. Strang and myself do our karaoke act on these Zoom calls to end it. We love a microphone. We love a microphone.
Woo, I didn't know this was going to be, you know, James Corden style. I should have prepared. Thank you.
That's news to me, Candice.
Well, thank you both for making time in your busy schedules. And I want to say also thank you so much to Bryce and Natalie for your thoughtful presentations today. We're wrapping up this final webinar in the series today. I want to remind all of you, the recording will be available later this week on CPHA's YouTube channel. You can find the other webinars there. We encourage you to share these with your colleagues and networks. Thanks for all of the interest and questions. I know we had our presenters also responding to questions in the chat for some of those more detailed questions on things that were shared today. Really appreciate your attention and thoughtfulness today. And a big, big thanks to the organizing team and technical support who made these webinars possible. You're rock stars. Thank you so much. Before we part ways today, just a few upcoming things that may be of interest from some of our host organizations before you leave. The Canadian Immunization Conference will be held virtually this year from December 8th and 9th. It is hosted in collaboration with the Canadian Association for Immunization Research, Evaluation and Education, the Canadian Pediatric Society, the Public Health Agency of Canada, and of course by the Public Health Association of Canada. Also look out for that position paper. It will be coming in early 2022. Later this month, the Canadian Centre on Substance Use and Addiction will be holding their virtual conference, Issues of Substance. This is the place to go for substance use and addiction. So please feel free to log on here to learn more, register. The Canadian Cancer Society, hot off the press, just last week released their Canadian cancer statistics. It provides really great detailed information on the impact and burden of cancer in Canada. And Dry February 2022 is in full swing. This is a fundraiser challenging Canadians to go alcohol-free in February and raise funds. And an overwhelming majority of participants who've completed this challenge in the past indicate they would actually drink less alcohol after participating in the campaign. So that's pretty cool way to test out if that's something that is possible for you. And last but not least, a reminder that we at the Canadian Partnership Against Cancer have alcohol policy resources available. You can click the link at the bottom and get a good scoop on evidence, economic evidence, public perceptions, and all the types of policy actions being taken across the country, as well as shifts since COVID-19. So as you leave today's webinar, you will be automatically redirected to a 3-minute evaluation survey. Please fill it out if you have 3 minutes. We really do value that feedback. Thank you, everyone, so much for your time and attention today. Stay safe. Hope to see you soon at one of those virtual events we just spoke to in the coming weeks. Bye, everyone.